Scott Hall here. Case today, 18-year-old male tennis player, right-handed, presents to a primary care sports medicine clinic for evaluation of right shoulder pain and weakness at the start of his season. He had noticed a progressive decline in performance within the past year, which ultimately prompted him to be evaluated. His symptoms were localized to the right posterior lateral shoulder, which he described as mild, dull muscle soreness. His symptoms were exacerbated with tennis play and improved with relative rest. He endorsed weakness and described it as mild with external rotation. He had no sensory loss or described no numbness. Initial examination revealed decreased strength with external rotation of the right shoulder, with the authors rating it as 3 out of 10. They noticed moderate atrophy of his right infraspinatus and preservation of the supraspinatus. There was no point tenderness and no sensory deficit on exam. He had full active and passive range of motion of the shoulder without instability. A shoulder x-ray was described as unremarkable. EMG and nerve conduction studies demonstrated normal nerve conduction, but the EMG was significant for abnormal spontaneous activity and neuropathic changes limited to the infraspinatus with preservation of the supraspinatus, which indicated a chronic suprascapular neuropathy localized to the spinal glenoid notch. MRI arthrogram was negative for compressive pathology and showed an intact labrum and rotator cuff. Since there was no anatomic anomaly attributed to the patient's symptoms, he was referred for physical therapy. Unfortunately, this was during the COVID-19 pandemic, and he was unable to stay on campus and was lost to follow-up. But he represented 15 months later and had not completed any formal physical therapy, but he had continued to practice and play tennis. His examination was notable for markedly increased atrophy of the infraspinatus and stable weakness with external rotation, again graded by the authors as 3 out of 5. He was referred to orthopedics, and repeat MR arthrogram showed severe atrophy of the right infraspinatus and marked hypertrophy of the teres minor when compared with the imaging obtained 15 months prior. Repeat EMG demonstrated progression of abnormal spontaneous activity and neuropathic changes in the infraspinatus with continued preservation of the supraspinatus. Due to the extent of the atrophy, the orthopedic surgeon did not think it would recover with a decompressive surgery. The patient returned to full team activities without restriction, but with careful monitoring. Shout out to the authors. So this was from the journal Cureus. It was published in 2021. The authors Clayton Walker, Christian Belisario, and John Vasudevan from the University of Pennsylvania. So nice case report. I'm going to quote their conclusion. This case report highlights the importance of compliance with physical therapy when treating suprascapular neuropathy by showing the potential consequences of continuing sports participation without addressing the underlying pathology. The patient developed irreversible atrophy of his infraspinatus, but preserved some strength through hypertrophy of other external rotators, namely the teres minor, allowing him to continue to play tennis at the NCAA Division I level. Although he complained of a decline in performance on presentation, continued follow-up will be needed to address and assess if these compensatory mechanisms can completely compensate for his infraspinatus weakness. So, suprascapular neuropathy. I'm anticipating at least one test question on my CAQ exam. So, for those who don't know me, I'm Scott Hall, primary care sports medicine physician with the University of Utah. I'm preparing for my 2006 recertification in sports medicine. I'm trying to go through things case by case, and I'm hoping you can learn something while I'm at it. So suprascapular neuropathy, it's a nerve injury or dysfunction causing posterolateral shoulder pain, weakness of the external rotators, and muscular atrophy. It can affect the supraspinatus and the infraspinatus. It is increasingly recognized but can be overlooked as a cause of shoulder pain. The anatomy and physiology demonstrate two possible compression sites. the suprascapular notch, which is proximal, and the spinal glenoid notch, which is more distal. I've included my sketch of the anatomy on the thumbnail, where you can see the suprascapular nerve travel through the suprascapular notch and then through the spinal glenoid notch to innervate the infraspinatus. So a common test question may be to identify where the nerve lesion exists to test one's knowledge of anatomy. The etiology of neuropathy can arise from compression. Ganglion cysts are described in the literature as the most common space-occupying lesion, with a secondary possibility of soft tissue masses. Traction injuries can recur from repetitive overhead activities, like the one in the case report. Additionally, massive retracted rotator cuff tears can also contribute to suprascapular nerve dysfunction. Direct trauma is a possibility, as are inflammatory processes. The clinical presentation is very similar to what I described in the case report. Posterolateral shoulder pain and weakness, with the atrophy patterns demonstrating a distinction between, does the neuropathy occur at the spinal glenoid notch or the suprascapular notch. If it affects the more proximal suprascapular notch, it will influence the supraspinatus muscle. If it occurs in the more distal spinal glenoid notch, it will only affect the infraspinatus. So one expects to have weakness in shoulder abduction and external rotation. The diagnosis is based initially on a physical examination with a detailed history, but there are two diagnostic studies that were described in the case report, and one would be electrodiagnostic studies with an EMG and nerve conduction studies, which can identify the location of nerve dysfunction, with an MRI offering some additional information. The MRI can identify, as in this case, muscular atrophy or edema, and it can also identify any soft tissue masses or space-occupying lesion. Additionally, it could evaluate the integrity of the rotator cuff and look for a pathology there. Treatment is initially conservative with physical therapy and activity modification. There are surgical indications if there is extrinsic nerve compression from a mass lesion, or potentially from progressive pain and weakness despite conservative management. In the literature, there are both open and arthroscopic approaches identified. Outcomes, generally, they do demonstrate improvement with surgical decompression in the context of a space-occupying lesion, but strength and muscle bulk recovery are less predictable. Based on this information and as outlined in the case report, early diagnosis can be important, as chronic neuropathy can have irreversible atrophy of the affected musculature. I've left in the show notes the citation for the case report. I thought it was a really good job by those authors, and some other key references related to suprascapular neuropathy. Thank you for your time.